All right, can you folks see my screen? Yes. Okay,
We
cool.
can.
All right, thank you. Well, good afternoon, everyone, and welcome to this month's School Health Services Multidisciplinary Information Session. I am Erica McAllister, the School Health Services Liaison with the Nevada Health Authority, and I'm really glad that you all could join us today. Each month, these sessions are focused on different topics that connect health and education through Medicaid. And today we're going to be diving into assessments. Assessments are the starting point for identifying what a student needs to be healthy, supported, and ready to learn. Whether that's a nursing assessment that helps shape a plan of care or a behavioral health evaluation that guides treatment planning, both play a vital role in school health services. So, first, I would like to ask our speakers to introduce themselves before we get started, and we can start with Dr. Pebbles, please.
Good afternoon. Hopefully you guys can hear me okay. I'm having some technical difficulties this afternoon. So I'm Christine Pebbles. I'm a psychiatric nurse practitioner. Here I serve as the behavioral health clinical advisor for the State Department of Medicaid, and I also practice as a provider out in the community. So it's nice to meet you all. I know I have had the pleasure of meeting some of you, and for those I haven't met, it's nice to meet you.
Thank you. And Sheri?
Hi, I'm Sheri McPartlin. I'm the chief nurse for the Clark County School District here in Las Vegas, Nevada.
All right, thank you, ladies. So before we begin, just a few quick reminders. This session is being recorded and will be posted to our website, which is schoolhealth.nv.gov, on our office hours tab. That way, if any folks are unable to join live, they can go back and watch, or if you want to just go back and watch anyways, it will be up there by next week. So, and then at the end, we're going to have a Q&A period of time. So if you have any questions, you can save them for the end, and you can either raise your hand or put them in the chat. All right, so I will be handing it off to Sheri.
Okay. So we talked about the different types of assessments that are nursing related or other types of related services assessments that are completed within the school setting that we can bill for, into Medicaid. Health assessments for special education, health assessments for chronic conditions that are maybe outlined in a plan of care. A part of a health assessment, which would be a health and behavior interview with a parent in person. And then the MDT of a medically complex health assessment. We're going to just talk briefly a little bit on that. So the components of an assessment must be completed by an approved provider under the scope of practice. So RNs would fall into that category. Other related services providers that would also qualify might be a speech therapist as they do their assessment, or a physical therapist, or other providers. The assessment related to nursing must include the date of service, the category type of service or the type of assessment that you're doing, a start and end time and duration in minutes of how long it's taking you to do that assessment. Any referrals that are components of that assessment. So for example, if you noticed a high blood pressure, or maybe you needed to do a referral for an ear infection or some sort of drainage or rash, then those all would be noted within the assessment itself. Progress notes or documentation of your assessment also needs to be included, in addition to the provider name or the NPI of the provider authorizing the service. So, for example, in a plan of care that would be authorized with the provider, that would be outlining why you would be doing the assessment, or underneath the guidance through an NPI of an IEP. The NPI number would also be provided there. So the electronic medical record should have some components when you're documenting your assessment. You should have an ability to view the assessment for audit purposes. So being able to go back and take a peek at it and make sure there weren't any changes, or if there were changes, to have the ability to see what was changed and what was added prior to the information being saved. And then the ability to not allow the event to be modified or changed once the assessment has been billed. So there needs to be some sort of provision in your documentation system that the individual provider that is doing the assessment cannot go back in and change that assessment. And the electronic signature of the registered nurse, or whoever is completing the assessment, also should be included within your documentation piece. So those are all things, as you're looking for an electronic medical record, that you want to make sure you as the provider can go back and ensure that those are basically quality assurance pieces that you want to make sure are within your documentation system. Health assessments within a plan of care. The components of the plan of care must be met, but you want to make sure you're looking, so you know, as the provider that is doing the assessment, you're going to be looking at that health condition and that diagnosis, any type of treatment or frequency that needs to be provided, so you can specify your assessment to those particular areas. Looking at any short-term objectives or goals for treatment interventions. Also looking at a time frame for the evaluation of progress. So whether you're doing a health assessment for a student that might be starting on a course of a nebulizer treatment or some sort of respiratory therapy, you're going to be looking at what that time frame looks like, so that way you can evaluate, is the individual progressing, is that child progressing as appropriate? And through that assessment process, you'll be able to look at those things. So you want to make sure that has that component in there. The treatment must be only authorized during the time that it is written in the plan of care, and generally it's not longer than 1 year. Plan of care can be reviewed and renewed annually or more often as medically necessary. So you may have a plan of care that's outlined in something for, like, maybe a respiratory ailment, or an individual that is undergoing treatment for juvenile arthritis, or even a student with diabetes. All of those might be renewed more frequently to ensure that the treatment is appropriate. So the components of those assessments would be outlined in there, and you would be communicating with that provider should you find something that is abnormal through that referral process or through a clarification with the provider. So sample plans of care. So in the Clark County School District, we developed a lot of our plans of care to outline through medical orders, because a lot of those are continuous in providing other types of care. So for the examples that I provided regarding maybe a student with asthma, you might have a plan of care outlined for an asthmatic with different components in there in regards to education, to treatment for the actual, maybe the nebulizer or other types of respiratory therapy. In addition, though, you're going to need to have that information in there for your assessment. So you're going to have that baseline assessment for where you started, and that would be all outlined in that component of a plan of care. So in order for you to ensure that you have those components, you need some sort of tracking mechanism. So in the Clark County School District, on all of our orders, we have the components of the plan of care embedded within the orders. And then we have a sample checklist on the bottom here that we utilize here to ensure that we are making sure that our plan of care is complete when they accept the order. So does the student's name and their date of birth listed on there? Is the diagnosis listed on there? Sometimes the provider, the physician, forgets to include that. Is a licensed healthcare provider's name, signature, date, and NPI number outlined on the bottom of, on the bottom of the order? Has the parent guardian signed and dated the order? Another component of the plan of care is that the school nurse's name and signature and date is also outlined in there. So we utilize something like this, some sort of a simple checklist form, in order to make sure that we are meeting all the plan of care components. A health and behavior history interview. is another type of assessment that can be outlined and utilized in the school setting. So it's often what you are doing with the parent when you're gathering that information. You're looking at socialization, you're looking at mental health, you're looking at their previous medical history, you're looking at family history. All of those components are utilized to be able to get a full picture of that individual child. So things like medications, responses to medications, any medical procedures that they might currently be receiving or ones that they've had to have in the past, recent hospitalizations, functional abilities in the school setting. Do they need to use a walker? Are they in a wheelchair? Those types of things. Can they ambulate to and from different classrooms, or do they need assistance? Any risk factors, looking at diet, sleep, and other chronic medical conditions that might be present. And then that family history. All of those components within a health and development history, which is part of your assessment, would be included in some of your more complex medical students. Often in the Clark County School District, this is what we begin when we're looking at that initial assessment, because we're trying to figure out what accommodations we need in the school setting that can make the child successful educationally. So we have to look at that whole picture, looking at both family history as well as their sleep and their diet patterns, their eating habits, all of those things, so we can develop a good functional 504 or IEP or plan for this individual student. Your health and developmental history also would include documentations for any referrals to community agencies, whether it be a medical provider or maybe a social services, like maybe they need to get connected with Medicaid, maybe they need a social worker, maybe they need some sort of outside agency to help make them successful. Not to exclude things like housing or maybe a workforce connection or those types of things, because all of those components impact a student's ability to function in the educational setting. Also, when we're looking at our health and behavior interview, we're looking at any educational impact statement. Do they have or do they not have? Looking at this health history, you're going to want to analyze that data that you're collecting with the parent to determine whether or not there is an educational impact. And then any medical follow-up on needs, whether it's a medical referral that you're giving for vision, hearing, or some sort of medical condition that might be disclosed during the assessment. And then any resources that family might need to be able to meet those medical referrals. So your nursing assessments, whether it's within an IEP or a plan of care, can be utilizing the T1001. You can utilize that code for billing. It is limited to 2 units per day, and that's based upon a time frame of minute duration. So you would just be documenting your minutes that we outlined in the beginning during the plan of care, and it would roll into how many of those minutes would be provided. So in general, in the Clark County School District, the way that we have outlined it is the nurse just documents for the time it takes for her to do the assessment. That assessment might take 45 minutes. It might take 30 minutes. It's really going to depend on the student, how cooperative they are, and the number of conditions or medical concerns that they may have. So utilizing those items, then you would utilize your duration and use that T1001 billing code. For the health and behavioral history interview, this one's a little bit different, and we did work with the state office to develop codes that would work for that type of assessment. For an individual student that maybe has minimal medical issues, minimal family issues, minimal socioeconomic issues that need to be addressed, you'd most likely be using that 99401, because that assessment that you're doing with that individual family, that health and behavioral health interview form that you're doing with them, would most likely not exceed the 22 minutes. However, we do have some kiddos that we take care of in the school setting that might be a 40-minute or an hour type of assessment. So you would need to utilize the code that reflects how much time that you spent. There does need to be some additional education on this end on the end user, because it's not something that just rolls up into the next code like the T1001 does. So what I mean by that is, as you're looking at your documentation system, the individual provider, the end user, would need to know that it was no longer than 22 minutes, and we're going to use 99401. Where if the time frame was in that 23 to 37 minutes, then they would need to know to use that 99402. So there does need to be education from the school district to the end user so that they know how to document appropriately. The other part of that whole assessment process, because it doesn't just end with just the interview with the parent and the assessment of the individual child, but it also goes into the next step, that IEP MDT meeting with that parent, guardian, and student present or not present. Some components of care that you're going to be discussing in the assessment or in the interview would then go into that IEP MDT meeting, because those are the accommodations that you're going to be putting in place to make the child successful educationally. So generally, it needs to be about 30 minutes that you're talking about their medical components within their, within their care. However, you're going to be looking at health goals and accommodations within that. So maybe for a kiddo that has juvenile arthritis, let's say, you might be looking at accommodations in PE. You might be looking in accommodations to lessen the workload of that individual student in any type of contact activity in PE. You might be looking at accommodations even for general classroom accommodations, such as maybe the student can't sit in a regular desk. Maybe they need some sort of adaptive desk. Maybe they need frequent breaks. Maybe they need reduced workload assignments. So all of those things are going to be discussed, because it all impacts or all relates back to their health. You need to use your nursing discretion here. I know nurses don't like to hear that, but they definitely need to be using their discretion. Discussions might include medication management, side effects that might be impacting them at the school level, any medical procedures that they might need during the day, any management for field trips or that are off campus, and any medical conditions related to transportation. Those are just a few things, but you're going to be looking at all of those components to encompass the whole school day in all settings. Bill for the time that you're in the meeting, that you're discussing this, interactions with the meetings to be able to support with what's billed. So interventions, accommodations, referrals, and medical informations all should be outlined when you're documenting your MDT or IEP meeting in your documentation system for billing. And billing can occur for virtual meetings of 30 minutes or greater. You don't necessarily need to be physically in person at the meeting. If you're at another location, you can, and you're participating virtually, you can bill for that virtually. So what we utilize in the Clark County School District is we have set up some different templates to help our nurses just document a little bit better. So we put prompts within our documentation system so that we make sure that this information is completed. So this is an example of an MDT meeting that's 30 minutes or longer. Some of the actions that are generally taken, and the comment section. So the comment sections in this one is documentations of services that are outlined in the student's MDT or IEP. What services are going to be provided as a result of this meeting? Any health-related discussions that were discussed during the meeting. It could be the parents' concerns regarding the student not being able to participate fully in PE, in the example that I was using about juvenile arthritis. It could be the need for the student to take breaks. It might be the need for a modified day. All that information should be outlined in your comment section here. And then any synopsis of health-related decisions that were made as a result of that meeting. Accommodations were put in place for the student to have maybe activity modifications. Or if it's a student that has asthma, it might be respiratory-related accommodations. It could be that the student gets transportation because they can't walk the required amount to get on get out of, to be able to take a school bus to school. They can't walk to school, so they would need a bus. All of those types of things would be in your synopsis of why the decision was made that was made during that meeting. So we put the prompts in there to just help guide the documentation, so we're not just having each nurse make up their own idea of what needs to be included in there. It helps keep documentation consistent, and it helps the pieces from not being missed. Billing codes for assessments, assessment meetings, those MDT IEP meetings where the health discussion is over 30 minutes. Assessment findings are outlined in that plan of care or outlined in the accommodations. So when the parent is present, it's that 99366, the medical team conference with the healthcare professionals face-to-face with the patient and or family. And then the 99638 is the medical team conference with the patient or family not being present 30 minutes or more by a non-physician healthcare professional. So utilizing the appropriate code. Again, in that drop-down scenario in the back here, we have both of those prompts outlined. Was the parent present? Was the parent not present? So that the appropriate billing code is then attached to that student's billing record. So just some considerations in billing documentation that we have found helpful in CCSD. Creation of those standardized licensed healthcare provider orders, which fully address the components of the plan of care to be able to fully utilize the expansion within the state of Nevada. That has been really critical for us to be able to bill under the Medicaid expansion with the plan of care components. That way, we don't have to send the order to the physician and have the physician then just write down whatever they might write down. We have the prompts on the standardized orders that outline all of those things. In addition, it outlines some of those short-term objectives that we're looking at. Because when you're looking at trying to meet medical needs of students, when you're looking to try to look at even maybe an individual with diabetes, when you're trying to address short-term objectives, which are really hard when you're taking an educational model and trying to dump it into medicine, what are those short-term objectives? So thinking outside the box that maybe the physician wouldn't be thinking about. Things like, the short-term objective would be that the student's blood sugar is within normal range, between 70 to 80% of the time. So maybe that would be one of your short-term objectives, or that the student is able to truly identify what a low blood sugar feels like, and those short-term objectives. So those are already outlined. So that way, it's not something that we need to reinvent, because it's pretty much going to be the same for all components of diabetic care and assessment. When you're trying to build those types of things. So the plans of care within the licensed healthcare provider orders were key for us. Utilizing a billing extract within your current EMR. So in the Clark County School District, we have had Frontline, which is Health Office Anywhere, since 2007. We have about 300 nurses, 300 to 350 nurses that utilize that system on a daily basis. Up until about 2 years ago, the expectation was that the nurse would document in the electronic medical record and then also document in a separate billing system. And even with us being able to try to compare and contrast the two different systems, I knew we were missing out on tons of documentation. The expectation to document twice for services is really unrealistic. So by building that extract into our current EMR, we were able to capture so many more things that we were not able to capture just billing with two separate systems. So maybe consider an extract if you do have, if your current EMR doesn't automatically bill. Templates within the documentation prompts to ensure you're addressing those goals in progress. Those template samples that I showed you, just putting them in there, building them right into your EMR, so that way your document is consistent. And then the last thing that was really key in helping us to just ensure that our documentation and our billing is correct is to implement EMR monitors. We call them in our district Medicaid monitors, but they're looking to make sure that that charting is correct and it includes all those required components. So centrally, we set up those monitors to be able to run reports from our current electronic medical record and have an exceptions report almost for things that aren't completed. There's things that have to be completed that are required, but are they completed in the manner that our district is outlining as the expectation? So we're constantly going back and we're reviewing those things. And then the other component of the EMR monitor that is central is the review of those codes that I discussed before that were rejected and looking at the reason why they were rejected. Were they rejected because the student wasn't eligible for Medicaid? Were they rejected because we were missing components of something? What was the reason why the billing code was rejected at the state level? So encompassing all of that to ensure that we're getting the maximum reimbursement from the state level, as well as from the care that we're already providing. We're already doing those components. We're already doing an assessment of that diabetic individual coming in for care. We're already doing the assessment for that student that is undergoing an evaluation for special education. So utilizing some of those things that we're doing to be reimbursed for that professional level of service that's being completed in the school setting. I'll throw it over to you.
So one of the tasks that I'm concentrating on currently is screening and assessment. Part of the DLJ settlement that we're concentrating on right now is changing some of the policies and the procedures surrounding mental health assessment. So one of those issues that we're coming against is the need to adopt a set of behavioral health screening tools. So set being the key word, we're trying to utilize tools that are currently in place at different environments. So juvenile justice, child welfare clinics, schools, primary care offices, all sorts of environments, trying to utilize that and put that together in a set that's kind of all encompassing. So there's certain parameters though that the DOJ has set forth for these sets of tools. One of them is that it be brief. So that could be interpreted in many different ways, but brief, hopefully meaning, 10 to 15 minutes or less. It needs to be something that's validated or nationally recognized. So something that, has research to back it up and some statistics to back it up as being, efficient and consistent along different raters. So if I rate it, somebody else rates it, it should be relatively the same. It needs to be specific to mental health. So it needs to screen for things like depression, suicidal ideation, anxiety, ADHD. There's other terms that are used like externalizing factors, internalizing factors. It needs to be able to screen for that, and it needs to be developmentally appropriate. So sometimes that's the biggest hurdle to get over, is it needs to be appropriate for whatever that age range is for the child or whatever their developmental level is. So that's one of the issues that we're looking at. And so that's one thing I want you to keep in mind, is it's a set of tools. So we're not going to necessarily mandate that you change something that you're currently doing. We're going to try to include whatever it is that you're utilizing, so long as it's appropriate in that set of tools that needs to then be utilized for all children in the state of Nevada, and especially for those children that are covered under Medicaid plans. And then as well, this is the part that kind of applies to the schools and the educational departments, is that the DLJ also specified that there needs to be a new requirement. Children under Medicaid programs need to have periodic screening. And so the tools that we just discussed need to be utilized in order to do this periodic screening. And the state will have the task of making sure that these things are done correctly and that they're quality. This is a new requirement. And so this is something that we're looking at as far as the schools possibly being able to implement. And of course, we're working on billing, right? Because there should be some kind of compensation for this work that you're doing. But this gives us a baseline for the child, and it gives us the ability for us to monitor their behavioral health before we get to, the higher level. So if that's the MTSS levels that we're utilizing, it should be something that we catch before we get to the last level, so that we can either take care of it in the school if it's mild to moderate, or we can send them out to community providers for assistance before it gets to the point of suspensions and expulsions and multiple absences and any kind of academic kind of failure. Hopefully that's the intent of it, is to make sure that we're catching it before it gets to that point. So let's see, I have a couple of examples of what these screening tools might look like. This is one that's utilized in a lot of primary care offices and pediatricians' offices. So the pediatric screening checklist, it is pretty brief, it is developmentally appropriate, and it is mental health specific. So you can kind of see in some of these questions that it goes over a large kind of variation or range of possible diagnoses or disorders. So you can see things like blames others for his or her troubles. That could be oppositional defiance, refuses to share, takes things that don't belong, worries a lot. So anxiety, seems to have less fun. So depression, fidgeting, unable to sit still. So the point of these screening tools is it should be something that runs the gamut of tell me if there's an issue, and then we go from that point. So just catching it at the very beginning. There are some other tools that are utilized. This is another one of them, not as brief as this pediatric screening checklist or symptom checklist, excuse me, but pretty intense and a lot more targeted for age. So the one that you see right here is for age 4 to 10. There's one for teenagers. This could be completed by teachers, by parents, by the child themselves. And again, this goes over a lot of different disorders and illnesses, including depression and anxiety and things that are concerning, such as conduct disorder, oppositional defiance, like I said, which is everybody's favorite, ADHD, even things like autism that we need to be aware of if there's any kind of a developmental delay. So the point of the DOJ settlement is to make sure that we are screening the kids appropriately, that we're catching baseline and progress, but we're also keeping them within the community, that we're not waiting until they're in that last tier and they're sent off to a residential unit. That's what we're trying to avoid. So screening is the main component of that. And that's my focus for right now, is basically this screening and assessment. And hopefully we can come to some kind of agreement or policy or procedure that implements this within the school district itself. I know that I have had the ability to talk to a lot of people here that are on the meeting today, and a lot of screening is being done as far as suicidal thoughts. But the intent is to make sure that we are not missing things like depression and anxiety, bipolar disorder, any kind of psychosis, making sure that we're catching it before it gets to, for lack of a better term, the point of no return. So that's the point of this screening and assessment. And I believe that's it for the slides for me.
Yeah, sorry, it wasn't going to the next slide. All right, so we can open up the floor for any questions. Thank you, Sheri and Dr. Pebbles, for sharing. You folks can raise your hand. You can just unmute and take turns, put questions in the chat. Any of those options work for us. And we have about 20 minutes for a Q&A or just discussion. So we are all ears.
If nobody's gonna take the time, I guess I will. I know that we heard a little bit about this DOJ settlement and whatnot when you did the listening tour. I guess I'm still a little confused on what action do we as an LEA have? And if we have action, has that been communicated to the higher ups in our district on what that action is?
So when you say action, give me a little idea of
So
what you're referring
what
to.
do you want us to do? Do we have anything that we need to do on our own, or are we waiting for guidance from you all?
So we're waiting for guidance from the higher ups, for lack of a better way to say it. So soon we're going to have a summit where we talk to some of the community stakeholders, including the school. So my intent is to have the school district attend at the higher level too, at the state level. I've discussed this with them just briefly about, how can we implement this in the school? What does that look like? How disruptive is that? How easy is that? All of the above, and seeing if that's something that we can implement to something like, to give you an idea that was brought up by the state level, is this something that we do with testing that's done every year, right? Is this a 5-minute, 10-minute quiz that's done with the kids right before they take the testing for the year? Is that possible for us to get a baseline, just like we get a baseline for their academic process or their progress, excuse me? Is this a baseline that we can assess and see what their mood is like, right? Because obviously their mood in the summer versus the fall versus the winter is going to be quite different, but giving us an ability not only to track it, because it's multifaceted. I'm tracking the status. Of course, that's giving me the ability to take care of the child. But if I'm also tracking that status, it gives me an idea of how do we then accommodate as far as workforce is concerned. If we had a lot of kids that are dealing with a pretty severe amount of depression or anxiety, and we're having to refer them out, what does that look like? And do we have the workforce to kind of take care of that, right? So to give you an example, I myself have 4 kids. I had one of my kids that got a screening for suicidal ideation, came out positive. So I was contacted as the parent and then given a list of people that I needed to call. At the time, I did not do this for a living. I was a med-surg nurse working in a hospital, so I didn't know what to do at that point. From there, I kind of felt confused as a parent, didn't know what to do, but I had the sense of urgency of that the school called me and requested that I, take control of the situation, but I didn't know what to do from that point in time. And I feel like as we looked back as parents ourselves, you start recognizing like, oh, there were some indications that maybe there was something going on that maybe we missed, right? Every parent wants to think that they see everything, but it's just not realistic. So we were kind of left with, okay, could we have caught this earlier? Is there something we could have done? Could have there been an intervention before this occurred? Where did we miss it, basically? And so the point is to kind of make sure that that doesn't occur to anybody else, to make sure that we're catching it ahead of time. I've seen many, many kids have been expelled, that have been suspended, that have been kicked out of daycares and after school programs. And, you know, where was it missed? Was it the parents? What was going on where we missed it? And could we have avoided that? Could we have avoided the expulsions and the suspensions and hospitalizations? And is that possible? I don't know. And so that's what the point of the screening is can we see a baseline? Can we see a pattern, right? And how do we, once we see the pattern, once we have the data, is how do we address it then? How do we go about addressing it?
So
If that
this
makes
is,
sense.
yeah, so this is more informational for us at this point, if I'm understanding correctly. And then
Yeah.
we will be given our action once it's been decided how to respond to this DOJ settlement.
Correct, because my
Okay.
job at this point is to kind of elicit feedback from the community members and say, what screening tools do you use now? What screening tools have you used in the past? Which screening tools do you like, right? So I've worked for entities where we had to use a screening tool I did not like and I didn't find necessarily effective, but it's the one that I had to use. And so ascertaining that from everyone just to make sure I'm hitting hospitals and pediatricians and primary cares and schools and psychiatric providers like myself and therapists. And then we have to kind of compile all of that together and bring that now to the DOJ, to CMS, to the state, to an independent reviewer and say, okay, this is what we had as far as feedback from our community. These are the tools that they utilize. These are the tools that they like. And then the approval is really laying in their hands at that point to say yay or nay is, okay, this is your set of tools. Once that occurs, it's kind of a far-reaching system. So there will be MOUs with some county entities where these screening tools will have to be utilized, for lack of a better way to say it, but they're in certain circumstances. So in essence, they'll be like an algorithm. For instance, if a child presents to a child welfare clinic and they're there for more than 7 days and they don't have any behavioral health history, they will need to be screened. There's different levels of it, obviously, right? If you're in an emergency room and you have a behavioral health concern and that's why you're presenting to the emergency room, we don't necessarily do the screening tool because that's gate 1. Gate 1 is that screening tool. Gate 2 is more of like a clinical assessment. Gate 3 is a comprehensive assessment where somebody like myself, a psychologist, a therapist would go through and get total background, kind of like what was just intimated to, of like social background, what's your medical background, what's your family history, all of that. So it depends on the acuity level as if we use this screening tool or not. but that is the first gate. And later on, when the children's behavioral health transformation gets into full force, there'll be a 1-800 number, there'll be a website, and those entities will definitely use those screening tools to assess where do we go from here, how severe is it. So yeah, right now it's more informational, and this is to kind of give recommendations to the powers that be that then make the final decision, and then we go out and kind of disseminate it to all the different levels.
Melissa?
I love the idea of being able to collect, doing like baseline screenings and stuff like that. Thinking about it from how big our school population is from Clark County, are we looking at any electronic versions, or are we only looking right now at paper options?
Ideally, I would love an electronic version. Ideally, I would really like a main centralized system. So we're working on that, right? Because part of the problem is when I saw foster kids, when I saw them in ERs, when I saw them in rural clinics, the issue was if they had screening before, I didn't know what that screening was. I don't know what the outcome is. I don't know who screened them before. So, you know, ideally it would be electronic and it would be coupled with all those assessments before. So this poor child doesn't have to recount all of the information and, you know, answer all the same questions over and over again. So ideally it would be electronic format. And so this is one of the things in the summit that I will be covering. And one of the things I'm looking at when people do give me these examples of I really like this one, I like this one, I have to decide, you know, how is it available? What languages is it available in, right? Who can actually do the tool? If there's not enough staff, can the child do the tool? Can the parent do the tool? Can the nurse do the tool? So making sure that we're kind of hitting all those things to ensure that it is applicable, right? Because we're already dealing with a workforce shortage. I don't want to add any more burden onto anyone else. So if this is something that's electronic, the child can do it. That's the optimal way, right? But yeah, I would really love for it to be electronic so we can then collect data a lot easier and we can compare it, right? So I had an incident today where I had to look at scoring of a tool and I had one score here and one score there. And I'm like, okay, well, what does this mean? How did we get to that? Where was the difference, right? When you have 17 questions, which question was the one that triggered a higher score or a lower score? I don't know. So an electronic version of that would be ideal, definitely.
Melissa, so she's asking for suggestions. Do you have a suggestion on behalf of us?
I mean, there's like, I know I've used the SDQ in the past and I do like it, but it is definitely a more intensive one. And I don't know if I would default to that one for a tier 1 everybody screener, but there is there used to be a way you can input it into a system in the computer and they would spit out the score for you. But I don't know how that works with Dr. Pebbles. What you're saying is like a system where everyone has access to that. I'm not
sure if that were, yeah. And so that's why we're kind of coming up with all these different options of like, I agree with you, the SDQ is great, but it might be a little too intense for just, you know, right off the bat, like something like a PHQ, like too easy, right? Like, let me just ask you 2 questions, 3 questions, right? A GAD-7, let me ask you 7 questions and let me see if it really is severe. But you're right. I mean, it's difficult when you're dealing with a larger school district of how do we implement this without being burdensome, right? And making sure that it's quality and it's correct, right? So I grew up in the New York City school system. And so I understand what it's like to have a massive school system where it looks good on paper, but like, how do we implement it? So we're taking all of that in consideration as well of, you know, what does everybody use? What works? What doesn't work, right? Because I know even if research says this is a fantastic tool, if in use it really isn't feasible, then it's not feasible. Yeah, but thank you for the recommendation. I have that one on my very long list, the STQ.
Nancy?
So I'm coming from a totally non-mental health perspective. So I guess my question is more for Melissa and for Dr. Pebbles. So I know in the past CCSD used Panorama as a screener. I know it was never required for schools to use it, but is this something that would potentially be an optional tool?
Panorama, you said?
Yes, and Melissa could probably speak more to it than I can.
Panorama, we use Panorama more as an SEL type of survey. So if we're looking at it from a tier 1 perspective, kind of like the first one you just showed of like, hey, do you feel okay? Do you feel sad? Do you feel connected? Those types of things. I don't think Panorama is a good one to start making us looking at diagnostic categories, like when Dr. Pebbles was saying, bipolar or ODD or things like that. But from a school district perspective, it is a good way for us to toggle out maybe some of the kids who would need a more targeted screener, like the SDQ or something like that. But that's not the only option. I think there's a lot of options out there to explore. I think that's probably the hardest part in all this, is there's a lot of options out there and just finding the best one.
There are a lot. You are correct. And every environment uses something different, right? Juvenile detention, they're screening for sex trafficking, right? The child welfare clinic, they're screening for sex trafficking, where a pediatrician's office might not do that, but the pediatrician's office has kind of this assessment and schedule that they have to follow to screen for autism, to screen for the depression. When that child turns into those lovely teenage years, they're screening them at every single visit. And so it's very different. And then the screening that you might utilize or the questions you might ask in an ER or an ED is completely different than primary care. But I agree with you, like that would be an excellent way to assess at that tier 1, which kids are okay at that tier 1 where it's universal, which ones need the targeted, which ones need individualized, and then how do we assess that from the screening tools themselves. My intent in this summit is to give out randomized screening tools, basically with a hypothetical case scenario of, I want people to apply this case scenario to the screening tools. I want to see what the reliability is. I want to see how consistent that screening tool is across multiple people, because many of us in the mental health realm have seen these tools and we look at it and we're like, well, I did the same tool and I got a completely different number than you got, right? So how did you come to that? What's your rationale for answering a level 4 on this question? So my intent is to make sure that I'm testing the reliability too of those screening tools to say, okay, this person really loves this screening tool, but when we tested it, the numbers were all over the place. It might not be the best one for us to utilize.
Any other questions or discussion?
It would be ideal in this quest if this is something that we are all implementing, that of course it is electronic, and that of course we would be able to extract that information into our billing system as well. So just something to keep in the back of your mind.
Oh, yes. I can tell you in my life, documentation and billing are not good words in the household. When I say that, my kids and my husband know I'm pretty irritated if I'm talking about documentation and billing. It's not a good day, especially if I'm talking about both of them at the same time, right? And so making it transparent as far as billing is concerned is really important. Like Sheri said, you don't want to document twice. You don't want to have to document and then bill too. You want to be doing one task one time, and it should reach everything at once, because you need to be paid for the screening and it needs to be attached to the documentation. So yeah, definitely something I have in my mind. Absolutely.
All right. Well, if there's not any other questions, you can still interrupt or raise your hand. Feel free. I just want to say thank you to Sheri and Dr. Pebbles for today's presentation, and to all of you who joined and participated. A reminder that this session was recorded, and I will be posting the video, the slide deck, and then like a session summary with some of the Q&A portion, and that will go on our website. Our next session is going to be on November 18th, and the topic will be EPSDT. And I hope you guys will join for that. These sessions are registration required, so the link for registering is on our website. And if anyone has any difficulty getting that done, just email me. And then I've got Dr. Pebbles and Sheri's email and my email on their contact information and our website. And yeah, thank you all for your participation.
Thank you, everybody.
Bye.